today. Today we'll study the small as well as the large intestine. So these are the specific objectives related to this topic. That is, list the different parts of small as well as the large intestine, and then we'll discuss in detail about the different parts of the small intestine. That is the duodenum, jejunum, and as well as the ileum. Along with that, we'll also study the large intestine, which is also called as the colon. This is in relation to the shape, length, beginning, termination, peritoneal coverings, blood supply, as well as the lymphatic drainage. Then we'll try to differentiate between each part of the small intestine, as well as specifically related to duodenum, jejunum, and as well as the ileum. Then we'll study about some of the typical features of the large intestine. So to begin with, the small intestine. So the small intestine, as you know, it has the three parts: duodenum, jejunum, as well as the ileum. So there are three parts for the small intestine: duodenum, jejunum, and ileum. If you see the duodenum, it is fixed to the posterior abdominal wall. So it doesn't have a mesentery. So it is called as retroperitoneal. Whenever there is no mesentery and it is fixed to the posterior abdominal wall, then it is called as retroperitoneal. So the duodenum, most of the part of the duodenum is retroperitoneal. Coming to the jejunum and ileum, it has a mesentery, so it is more mobile. It is not behind the peritoneum, but it is within the peritoneum, so it is freely mobile. So here you can see here, this is the long mesentery. This is the peritoneal fold. Actually the jejunum and the ileum has been removed, cut, but you can see the long mesentery so that you can appreciate the mesentery. This is the fold, two folds of the peritoneum, which will hold here the small intestine, the jejunum and ileum. Compared with that of the duodenum, so this is the duodenum. So here, if you see here, it is in the posterior abdominal wall, totally adherent to the posterior abdominal wall. So it is behind the peritoneum. This is the peritoneal folds which you are seeing here, which are cut. So behind the peritoneum, this will be present. But the jejunum and ileum, as I said, it will have a long peritoneal fold. So it will be mobile because of the presence of this mesentery, but the duodenum is fixed because it has no mesentery. So the mesentery, as I said, this is the mesentery again. You can see here it is two layer of peritoneal folds. Okay, within which the part of jejunum and ileum will be present. So these are the two folds. If you can see, appreciate, there are two folds of the peritoneum, two layers of the peritoneum, connecting the small intestine to the posterior abdominal wall. So small intestine will be here. As I said, it is removed so that you can appreciate the peritoneum fold, and it is attached posteriorly. This mesentery is attached to the posterior abdominal wall. Okay. So this is called as the root. This is the root of the which is attached to the posterior abdominal wall. That is called as the root of the mesentery, and this is called as the free border. Even though there is no, it is not free, but it is attached to the small intestine, but it is mobile, so that's what is called as free border. The root, it is about just 6 inches. The root here, which is attached to the posterior abdominal wall, is 6 inches, but the free border is almost 6 meters. So see the difference. Okay. So this is very long part, that is 6 meters, but when we go behind, it is attached to only a small area, that is the 6 inches. So that is the difference between the root and the border. So the root is 6 inches. It extends from the duodenojejunal junction to the ileocecal junction. That is the beginning from the duodenal end and the beginning of jejunum. That is called as the duodenojejunal. End of duodenum and beginning of jejunum, because duodenum is totally fixed. So this root begins from the duodenojejunal junction. So here you can see here part of the jejunum. So a part of duodenum and then jejunum, that is called as the duodenojejunal junction to the ileocecal junction. This is the ileum. Okay. This is opening into the cecum. This is the first part of the large intestine. That is called a cecum. So this junction is called a ileocecal. Here it is duodenojejunal junction to the ileocecal junction. So this is the total length of the total length of the jejunum to the ileum, and this is attached to the posterior abdominal wall as a root. The free border, as I said, is 6 meters. It contains the jejunum and the ileum and the blood vessels. If you see here closely, they can see here there are small structures seen, the red and blue structures. These are nothing but the blood vessels, the arteries and the veins, which are supplying the jejunum and the ileum. So they contain the jejunum and ileum and the blood lymphatics, the blood vessels, lymphatics, nerves, as well as even small quantity of fat. So all this will pass between the two layers of this peritoneal fold. So here you can see here a part of the peritoneum has been shown, this the root here. So you can see the root. This is the root of the mesentery, and this whole mesentery has been removed, so you can see the root. So here is the duodenal junction. Here you can see the duodenum jejunal junction, and this is the ileocecal junction. Okay. Before we go further, there is a general rule for blood supply. If you remember this general rule for the blood supply, you can easily remember the blood supply of all the parts of the GIT. So depending on the development, embryological development of the gut, that is the GIT, its arterial supply is supplied by specific arteries. The whole of the GIT is divided into three parts: the foregut, midgut, and the hindgut. Foregut, midgut, and hindgut. So esophagus, the pharynx, esophagus, stomachs, up to the second part of the duodenum. This is the duodenum here. This is the duodenum. Up to second part of duodenum, where the duodenum, the pancreas open here, major duodenal papillae. So up to here will be the foregut. So it is supplied by a specific artery called as the celiac trunk. Celiac trunk. Usually it is also called as celiac artery, but because it is very short, so it is called as trunk. Celiac trunk. It is the artery. Then from beginning from here, second part of duodenum up to the transverse colon up to here will be the midgut. The medial two-thirds of the transverse colon, junction between the medial two-thirds and lateral one-third. Here up to here will be the midgut, and it is supplied by a specific artery called as the superior mesenteric artery. All these are the branches from the abdominal aorta. This is the abdominal aorta. From there, celiac trunk, foregut, midgut is supplied by the superior mesenteric artery, and the hindgut from here, from this junction up to the whole of the up to the rectum. This whole thing is supplied by the hindgut. This is developed by the hindgut. When you study a development, you will come to know the foregut, midgut, and hindgut. But there is a specific artery for all this part. This is called as the inferior mesenteric artery. So these three arteries will supply the major part of the gastrointestinal system. The foregut, which includes, as I said, the pharynx, esophagus, stomach, up to the second part of duodenum. This is supplied by celiac trunk. The midgut is supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. So if you know any part which is developed from which part, then you can see easily mention that specific artery. Okay, even though there are specific arteries there, but this is the common artery which will be giving many multiple branches. So it will be one of the branches from these arteries, either the celiac trunk, superior mesenteric artery, or the inferior mesenteric artery. So if you know which part it is belongs to, whether it belongs to foregut, midgut, or hindgut, then you can easily mention its blood supply. Coming to the relations between the embryological origin and the arterial supply of the duodenum, jejunum, and ileum. As I said, the duodenum up to the second part here, second part of the duodenum has different parts we'll discuss. Up to this part, so this whole thing is supplied by this is part of the foregut, so it is supplied by celiac trunk. Below that, this is part of the midgut. This is the third part and fourth part of the duodenum. So this is supplied by the superior mesenteric artery. So the duodenum will be supplied by the two arteries because it is developing origin from the foregut as well as partly from the midgut, partly from the foregut and midgut. This is the duodenum here. So which is retroperitoneal, totally adherent, non-mobile because it is retroperitoneal. This is the duodenum. Up to here will be developing from the foregut, and below this will be from the midgut. So the arterial supply will be by two arteries. Artery of the foregut will be the celiac trunk, as we saw before. So this is the celiac trunk. Then the artery of the midgut will be the superior mesenteric artery, superior mesenteric artery, artery of the midgut. So these two arteries will be giving blood supply to this part. So if you know the development, If you know whether it belongs to foregut, midgut, and hindgut, then easily you can mention the arterial supply. Similarly, if you see the jejunum and ileum, they are part of the midgut, as you can see here. So the remaining part of the jejunum and ileum, whole thing is belongs to the midgut. So it will be supplied by the superior mesenteric artery. So it is supplied by the artery of the midgut, that is the superior mesenteric artery. This is how you can easily deduce which artery supplying which part of the gut. Okay, so here you can see the picture. This is called as the celiac trunk. So which is, as soon as it is very short artery, this is the abdominal aorta behind, so it is giving a branch. It's called a celiac trunk. As soon as it comes, it will break up into many arteries, so that's why it is short. It is called a trunk, even though it is artery. Then here is the superior mesenteric artery, which is going behind the pancreas. So this is the pancreas here. This is the head of the pancreas, and this is the duodenum. So this is the superior mesenteric artery. It will be giving branches to the remaining part of the duodenum. The upper part will be supplied by the celiac trunk. Okay. Now coming to some of the features of the duodenum. Duodenum is, as you can see here, it is C-shaped structure. The capital C of the English letter. So it is C-shaped loop, and the total length is almost 10 inches or 25 centimeters, beginning from the pyloroduodenal junction. As we have seen before, the end of the pylorus is the last part of the stomach. So it will continue as the duodenum. So the junction is called as the pyloroduodenal junction. Okay, it begins from the pyloroduodenal junction and terminates at the duodenojejunal junction, because it will continue as the jejunum. So it will here, this is the duodenum here. So it will continue jejunum. So the junction is called as the duodenojejunal junction. So beginning is from the pyloroduodenal junction, termination at the duodenojejunal flexion. And peritoneal covering, as we know, it is retroperitoneal. Most of the part of the duodenum is retroperitoneal. It is behind the peritoneum, so there is no mesentery. So it is divided into four parts. Four parts. We'll talk about that. Four parts. Embryological origin. It is developing, as we already saw, from the foregut and midgut. So the arterial supply will be from two arteries: artery of the foregut, that is the celiac artery, and the artery of the midgut, that is the superior mesenteric artery. Similarly, even the lymphatic drainage is from two parts: the celiac lymph nodes, which is draining the foregut, and the midgut will be drained by the superior mesenteric lymph nodes. So the origin, the blood supply, and the lymphatic drainage will be similar to that of its origin. Now coming to the parts of the duodenum. Okay, so if you see here, there are four parts: first part, second part, third, and fourth part. The first part is horizontal, this part. So here is the pylorus part. It continues as the pylora of the stomach. It will continue as the duodenum. First part. So this is the first part of the duodenum. Then we have the second part. This is called as the descending part, or the second part. Then we have the third part. This is called as again the horizontal part, and the fourth part, which is going ascending. If you see here, this is the first part, second part, third part, and the fourth part. These are the four parts of the duodenum. So the length is, the first part is 2 inches, the second part is 3 inches, the third part is 4 inches, and the fourth part is 1 inches. So instead of 1, 2, 3, 4, it is 2, 3, 4, 1. 2, 3, 4, 1. So this is how we can easily know. It is in inches. 2 inches, 3 inches, 4 inches, and 1 inch. The last is very short, it is just 1 inch. So what is the level? So for the first part, it is at the level of the transpyloric plane. As you know, here there is pylorus. So if you draw a line through the pylorus, that is called as transpyloric plane. So it passes through the transpyloric plane. And the descending part, it is long, so it descends from the L1 to L3 level. Then this third part will be from the L3 level, that is called a subcostal plane. This is the horizontal imaginary line here, that is called a subcostal. Then the ascending part from the L3 to L2 goes, then it continues as the jejunum. So these are the four parts of the duodenum and their inches: 2, 3, 4, 1. Now coming to some of the important relations of the duodenum. Coming to the first part, if you see here, so this is the pylorus, again to the pylorus of the stomach. Okay, then it will continue as the first part of duodenum here. So the anteriorly, if you can see the liver, so here the liver has been lifted, so you can appreciate. If not, it is totally covering the first part of the duodenum. So it will be hiding behind the liver. So here it has been lifted so that it can be appreciated. So this is the anterior relation. Posteriorly, we have if you can see here, this is the bile duct going behind the second part of the duodenum, first part of the duodenum. This is the bile duct. Then we have the gastroduodenal artery. There is an artery which is going down. This is called as the gastroduodenal artery. So that is there. Then the portal vein. This is the vein behind, big large vein. So this is called as the portal vein. So this is the oblique vein which is going like this, which is going and supplying the liver. So these are the three structures which are posterior: bile duct, then the gastroduodenal artery, and behind that is the pyloric vein, the portal vein. Now coming to the relations of the second part. So here, if you can see, this is the second part. As you know, this is the second part. So anteriorly, again, there will be liver. Again, the liver has been removed here so that you can appreciate. So anteriorly, we have the liver as well as the transverse colon. This is the transverse colon. This is the ascending colon. This is the transverse colon, large intestine, part of the large intestine. Then the coils of the small intestine, everything will be here. It all have been removed so that you can easily appreciate these structures. Okay, posteriorly, if you see here, the right kidney will be behind, posterior to that second part. Then laterally, we have the right colic flexure. This bend between the junction between ascending and transverse colon. This is called as the right colic flexure. Then medially, we have the pancreas. If you see here medially, so here is the pancreas, the head of the pancreas. To this is the duodenum, and medial to that is the pancreas. So what are the openings in the second part? If you cut the second part, you can see very important opening. There are two important openings. The common opening for the bile duct and the main pancreatic duct. If you see here, the bile duct, it is shown in green color. It's coming down and it is joined by this. This is the pancreas and it has a duct called a pancreatic duct. Both will join together to form a common opening for the bile duct and the pancreatic duct. Okay. So this will open into the second part. This is called as the major duodenal papillae. This is called as the major duodenal papillae. This is called a major because it is large, because there is a one more smaller one. This is called as the minor. There above there is a smaller opening. This is called as the minor duodenal. So this is called as major, means large duodenal papillae. Opening of the accessory pancreatic duct. So this is the pancreatic duct joins with the bile duct to form the open into the major duodenal. There is a smaller duct. This is called as the accessory pancreatic duct. This will open through the minor duodenal papillae, 1 inch above the major duodenal papillae. So it will open into the minor duodenal papillae. So here is the minor duodenal papillae, and this is the accessory pancreatic. The main pancreatic duct is here. The main pancreatic duct. So it is here, which will open along with the bile duct into major duodenum. This is the accessory, which will open into the minor duodenum. So these are the two important openings in the second part. Now coming to the third part. So third part is the horizontal part, this one. Okay. So this part anteriorly, as we know, will be the large coils of the small intestine will be present in the front, and the superior mesenteric vessel. If you see here, this is the superior mesenteric artery, this is the superior mesenteric vein. Both these vessels, which will be supplying the midgut, will be going anterior to the third part of duodenum. Okay, as you can see here. So they are coming from behind the pancreas and go in front of the duodenum, because the duodenum is totally behind the attached to the posterior abdominal wall. Posteriorly, we have the psoas major muscle. If you see here, this muscle here on either side, this is called as the psoas major, especially the right one, because the left is far away, but the right psoas major, as well as the inferior vein. This is a large vein. This is called as the inferior vena cava. Then we have the abdominal aorta. Just behind that, again, there is very important structures are behind this. So one is the psoas major muscle, then inferior vena cava, then the abdominal aorta. Three important structures are passing behind them. Along with that, even the inferior mesenteric vessel will be coming behind. From here, it is not shown in this picture. It will come. This is the superior mesenteric, which will be anterior, and the posterior we have the inferior mesenteric vessels. Coming to the fourth part, So here is the fourth part, very short part, just 1 inch. Anteriorly, we have the small intestine. Again, it will be abdomen is filled with the small intestine, so it will cover even the fourth part. Then posteriorly, we have the left psoas major. If you see here, behind that is the here is the right psoas, which is the relation for the third part. Left psoas will be in relation to the fourth part of the duodenum. Now going to the jejunum and ileum, the remaining two parts of the small intestine. It is coiled tube. As we know, it is a very long tube, so it is coiled within the abdomen, almost 6 meters, almost 6 meters long, almost 20 feet. Okay, so it begins from the duodenojejunal flexure, where the duodenum ends and the beginning of the jejunum, and terminates into the ileocecal junction, where it opens into the cecum, the large intestine. And the peritoneal fold, it has a peritoneal fold, so it is called a mesentery of the small intestine, as we already saw, the mesentery. Embryological origin, this duodenum and jejunum are both developed from the midgut, as we already saw. And the arterial supply of the this part will be from the artery of the midgut, that is the superior mesenteric artery, and the lymphatic drainage will be into the superior mesenteric group of lymph nodes. Now coming to some of the important relations between the jejunum and the ileum. So what are the important differences between the jejunum and ileum? How do you differentiate, okay, these two parts? If you see the length, it is shorter. The jejunum is shorter compared to the ileum. Ileum is 2/5, and the jejunum is the 2/5, and the ileum is 3/5. Okay, so if the whole of the from duodenum to the jejunum to ileum, if we divide to 5 parts, 2 parts will be for the jejunum and the 3 parts will be for the ileum. So it is longer. Okay, so it is 6 meters, as we saw. So it is 6 meters. So it will be almost 2.5 meters will be jejunum, and 3.5 meters will be ileum. And if you see the diameter, this part jejunum is wider. It will be much more wider compared to the ileum, which will be narrower. And if you see the wall will be thicker in case of the jejunum, because it will show foldings. Those are called as the plica circularis. Plica, these are the folds here from inside. These are called as the plica circularis. There are multiple folds, so the wall is much more thicker compared to the ileum, which has lesser plica. If you can see a very few here and there, so it will be thinner. Appearance, it will be dark and more vascular because of the vascularity. A lot of vessels will be supplying this part because of the absorption, so this part will be more darker compared to the ileum, where there will be lesser absorption compared to the jejunum. Okay, so it will be less vascular. And the vessels, they will be lesser arcade. So these arteries, before they supply the intestine, they form arches like this, the anastomos. These are called as the arterial arcade. Arterial because it is coming from the arteries, and arcade because they are forming arches. Okay, so these are lesser compared to the ileum. There are more arterial arcades. So they are shorter terminal branches. The branches are shorter, and here they are longer because the arteria arcade are less, so the terminal branches are longer. Here there is arteria arcade is more, so the branches are smaller. Coming to the mesenteric fat, so it will be small amount near the intestinal border. There will be small quantity of fat, but here in case of the ileum, there will be much more larger amount of fat will be present. Coming to the lymphoid tissue, there will be few aggregation of the lymphoid tissues here, but here in the ileum, they are very huge, and they form numerous aggregations called as the Peyer's patches. Very important again in case of typhoid fever. So these Peyer's patches play a very important role when we study the typhoid fever. At that time, we will study how these lymphatic aggregations will be infected. So these are called as Peyer's patches. They are much more in case of the ileum compared to the jejunum. So the ileum in histology will be identified because of the Peyer's patches. Okay. Now coming to the parts of the large intestine, as we already saw, the small intestine. Now we'll study the parts of the large intestine. So the large intestine is divided into three parts: abdominal, pelvic, as well as the perineal part. The part of the this large intestine which is in the abdomen will be the cecum, then a small extension called as appendix, then the ascending colon, the right colic flexure, transverse colon, and descending colon. All these are present in the abdominal part. Then the from the descending part, then it goes into the pelvis as sigmoid colon and the rectum. And finally, in the perineum, there is the anal canal. So it is divided abdominal, pelvic, and perineal parts. Okay. Coming to the some of the before we go into details about these different parts of the large intestine, we should know some characteristic feature with which you can easily identify that this is the large intestine, not the small intestine. Because clinically, when you operate, you make a very small incision, and sometimes it is very difficult to differentiate between the large and small intestine because the size sometimes will be similar. Okay, so because of that, we have to know three features with which you can easily find in the large intestine, the characteristic features of the colon or the large intestine. But these features are not present in the rectum and the anal canal, not found in the rectum and the anal canal. Which are those three features? One is the first one is called as tinea coli. Tinea coli. These are the three longitudinal muscle bands, one anterior and two posterior. You see here. So in case of the large intestine or the colon, you can see the muscular bands. This is called as the tinea coli. So one anterior and there will be two posterior. There will be two posterior. So these are called as the tinea coli. These are nothing but the longitudinal muscle fibers. Okay, so there are two types of muscle fibers. If you study the histology of the colon, the inner circular and outer longitudinal. So the outer longitudinal will aggregate into three areas. They form the tinea coli. This is only present in case of the large intestine. So this will be absent in the small intestine. The second is the saculations. Saculations means these are called also called as the hostra or hostrations. These are the back pouches like thing. So these areas, small pouches. Because the tinea coli are shorter, then they make it small areas. These are called as hostrations or sacculation. Tinea coli are shorter than the large intestine and they fold the whole of the large intestine to small cavities. These are called as the hostrations or saculations. Then we have something called as the appendices epiploicae, short peritoneal fold filled with fat. If you see here, there are small quantity of fat. You see here, these are the small quantity of fat within the peritoneal fold, which is covering the large intestine. These are called as the appendices epiploicae. Appendices epiploicae. Okay, so if you see here, they are mentioned here. Appendices epiploicae. Okay, so these are the typical features which are seen in case of the rectum. Sorry, in case of the large intestine, except the rectum and the anal canal. Okay, so if you see here, so it is present everywhere up to the sigmoid colon, but not present in the rectum and the anal canal. So they are absent. So these are the three features: tinea coli, the longitudinal muscle fibers, then sacculation or hostration, which are folds, then the appendices epiploic, nothing but the fat content. Okay, within the peritoneum. These are the three typical features which are present in the large intestine and how you can identify the large intestine and differentiate from the small intestine. Now coming to the peritoneal coverings, in case of the large intestine, there are differences. So the parts which are with the mesentery, that is the peritoneal fold, will be the transverse colon. Transverse colon, as you can see here. So this part of this is the transverse colon, which has a mesentery. Now here it is called as transverse mesocolon. Transverse mesocolon. Colon is the structure. This is called as meso. This peritoneal fold with the mesentery is called as mesocolon here. For small intestine, it will be mesentery. In case of large intestine, it will be called as mesocolon. This is because of it is attached to transverse. That's why it's called as transverse mesocolon. Then we have the sigmoid colon. Sigmoid colon. If you see, yes, this is the sigmoid colon. So it also has a sigmoid mesocolon. Then we have the appendix and the cecum also. Okay, so if you see here, this is the cecum, and a part of this mesentery is present here, as well as this is the appendix vermiform opening, which also has a mesentery. which is called as the mesoappendix. Except this, if you see here, this part has no mesentery. This part, the ascending colon, the descending colon doesn't have mesentery, so there is it is not shown here. But transverse colon has mesentery, so it is called as transverse mesocolon. Sigmoid colon has a mesentery, so it is shown as sigmoid mesocolon. The cecum has a mesentery, so it is called as the cecum mesocolon. So here there is a mesentery for the appendix, so it is called as mesoappendix. Okay. So these are the areas where we have the mesentery. Mesentery is present here. Then we have the parts which are retroperitoneal, means which are without the presence of mesentery. Those means the ascending colon, descending colon, and upper two-thirds of rectum. As you can see here, this is the ascending colon, this is the descending colon, and the upper two-thirds of the rectum. This is the rectum here, upper two-thirds of the rectum. So all these are with retroperitoneum, behind the peritoneum. And there are parts which are totally devoid of peritoneum. In case of retroperitoneal, they are at least they are behind the peritoneum, and only in the front there is peritoneum. But there are areas where there is no peritoneum at all, especially the lower one third of rectum and the anal canal. You see here in the lower part of the rectum, so this part is not having any rectum. Okay, as well as the lower part, that is the anal canal. All these don't have any peritoneal fold. Here at least you can see the peritoneal fold, but here there is no peritoneal fold. So this is how we can differentiate between the different parts of the large intestine. Now coming to the appendix, a very important structure which is very notorious for infections. Okay, and it leads to a severe infection of the appendix, that is called as the appendicitis, and it leads to severe pain in the abdomen. Okay, so how to trace this appendix? Okay, so the base of the appendix is marked by a McBurney's point. There is a point called as McBurney's point, which indicates the base of the appendix. Where is it? At the point at the junction of the lateral one third and medial two thirds of a line traced from the anterosupplex spine to the umbilicus. So here there is a bony structure called as the anterosupplex spine. You can easily feel your own. So that is the anterosupplex spine. From there to the umbilicus, if you draw a line, the junction between the lateral one third and medial two thirds, this junction for this line, the line is drawn from the anterosupplex spine up to the umbilicus. Then you join, then make it divide into three parts. The junction between the lateral one third and medial two thirds. This is the McBurney's point. This is the site where we can mark the base of the appendix, and this is the site of severe abdominal pain during if there is any infection of the appendix. Okay, so this is called as the McBurney's point. So if you see here in the if you divide the whole of the abdomen into quadrants and then see, this is how we can see this is the McBurney's point. Here it is present. It is present in the right iliac fossa, just below the cecum, and we saw where it is present. Okay, the junction between the lateral one third and medial two thirds of the line joining the anterosupplex spine to the umbilicus. Okay, so this is called as the McBurney's point. Now coming to the some more features of the appendix. Okay, so this appendix will be opening at the posterior medial aspect of the cecum. So it will be opening. This is the cecum, the first part of the large intestine, that is called as the cecum. So it will be opening into the posterior medial aspect of the cecum, just 1 inch below the ileocecal junction. Just 1 inch below this is the ileum and this is the cecum. So this is called as the ileocecal junction. Where the small intestine joins with the large intestine. This junction is called as the ileocecal junction. Just 1 inch below this will be the appendix. Okay, but as I said, this is very notorious and it will be changing its position. Okay, the base is fixed, so it cannot move, but this long appendix will be moving in different directions. So depending on which position it is present, it can be divided into different positions. So what are the positions? The most commonest will be the retrocecal. Means retro means behind, cecum, this is the cecum. So behind the cecum, that will be the retrocecal. It is behind the cecum. Retrocecal, which is the commonest. Then we have the pelvic, which is directed toward the pelvic, that is called as pelvic. Then we have subcecal just below the cecum. If it is present, then it is called as subcecal. Then pre-ileal and post-ileal. Ileum, as we have seen, ileocecal junction. So the ileum is coming here. Sometimes it is present in the front of the ileum, sometimes behind. If it is present in front, then it is called as pre-ileal, and if it is present behind, then it is called as the post-ileal positions of the. So these are the five important positions of the appendix: retrocecal, pelvic, subcecal, pre-ileal, post-ileal. But the most commonest will be the retrocecal. Now, relations between the origin and blood supply, as we have already seen. Okay, so what will be the origin, developmental origin, and how it will be blood supply of the large intestine. Okay, till the junction between the right two-thirds and left one-third. That is, this is the line showing you the right two-thirds and the left one-third. Up to here, so this whole from the beginning, from the second part of duodenum, jejunum, ileum, as well as the ascending colon up to here, transverse colon. So up to here, it will be supplied by the midgut. So all this is coming from the midgut. So it is supplied by the artery of the midgut, that is the superior mesenteric artery. And the nerve supply will be autonomic nervous system, including the sympathetic and the vagus. Okay, so these are the nerve supply and blood supply of this region. Then the junction from the right two-thirds and left one-third of the transverse colon, then the descending colon, the sigmoid colon, the rectum, all these are supplied by they are coming from the hind gut. They are developed from the hind gut, and hence they are supplied by the artery of the hind gut, that is the inferior mesenteric artery. And the nerve supply is also autonomic, just like that of the midgut, but it is sympathetic as well as the pelvic spine. In case of instead of the vagus, now it will be the pelvic nerves which will be supplying. Okay. Coming to the lower part of the anal canal, after the rectum is the anal canal. So the origin is from the ectoderm. So it is this anal canal, the last part of the GIT is not developing from the hindgut, but it is coming from the ectoderm. So it is supplied by a different artery called as the inferior rectal artery. And the nerve supply, because it is coming from the ectoderm outside, so it is supplied by the somatic nerve, that is the inferior rectal nerve. So this is the origin, blood supply of these different parts of the large intestine. Now coming to the venous drainage of the GIT, we studied the blood supply. Depending on its origin, it is the blood supply is different, but the drainage, venous drainage is slightly different and very unique. Okay, so veins draining the gut from the portal circulation. So they drain and they form something called as portal circulation, a very important circulation. All veins finally end into the portal vein. Here is the portal vein. This is the portal vein. So this is the splenic vein. This is the superior mesenteric vein. So this is the superior mesenteric vein, and this is the inferior mesenteric vein. And the splenic vein all drain into the portal vein. So they will drain finally into the liver. So all veins finally end into the portal vein, which enters the liver, and all the nutritions which are collected from the different parts of the intestine, it will be all flow into the liver for metabolism. So the superior mesenteric vein, the splenic vein behind the neck of the pancreas. So as you can see here, so there is a splenic vein, superior mesenteric vein, and the inferior mesenteric vein draining into the splenic vein, all drain into the portal vein. These are the tributaries of the portal vein. Okay. Now coming to the cecum, ascending colon, and descending colon, the anterior relations, some of the relations, important relations for these parts. Okay. So anteriorly, as we know, the whole of the GIT, the whole of the abdomen is filled with the small intestine. So all these are covered by the small intestine. Okay, as well as we have the wall of the abdomen itself, which will also cover the in front anteriorly to this part of the large intestine, ascending colon, transverse colon, descending everything. Okay. Then the greater omentum, there is a thick fold of peritoneum, which is called as the policeman of the abdomen. It has been lifted so that you can appreciate these structures. If not, it will be lying down on this all the structures. This is called as the greater omentum, the greater omentum, which is also called as the policeman of the abdomen. Now coming to the posterior relation of the cecum, ascending colon, descending colon. Okay, so here is the cecum, as you know. This is the ascending colon, descending colon is here. Transverse colon, because it has a mesentery, so it will be easily moving up and down. So we cannot exactly locate the posterior relation, but the ascending colon, descending colon, all these are fixed, so we know the relations. So for the cecum, so the first part of the duodenum, the posteriorly we have, these are the posterior relations. We have the psoas major. This is the muscle, psoas major muscle, which is coming down, so it will have the posterior, as well as iliacus. There is one more muscle coming from the lateral side. So together they are called as iliopsoas muscle, one muscle. Okay. So this is the iliacus, and this is the psoas major muscle coming, and they form the posterior relation. Then we have the ascending colon. So what are the relations for the ascending colon? One is the iliacus. This is the iliacus which is there, as well as one more muscle here. There is there, that is called as the quadratus lumborum. If you can see here, small part of the quadratus lumborum on either side. So this is the for ascending colon, it will be the right side part of the quadratus lumborum, which will form the posterior relation. Coming to the descending colon, this is the descending colon here. We have the left kidney here. Then we have the quadratus lumborum on the left side. Then we have the iliacus here, okay, and the psoas major muscle. All this form the posterior relation for the descending colon. Coming to the transverse colon, as I said, the transverse colon will be mobile, so it will be moving most of the time. So it is difficult to locate, but we can. There are some important relations which are always attached to it. So one is the greater momentum, as you saw. So this is the greater momentum, which is now you can see here it is lying down. So here it was lifted. So it was lifted here, greater momentum, but now it is in the normal position like this. So this is the normal position. So here it is lifted, here it is down. Okay. So then normally it will be the anteriorly will be the whole of the abdomen is covered by this greater momentum as well as the anti-abdominal wall. Coming to the superior relations of this transverse colon will be the liver, as you can see here. This is here will be the transverse colon. So just above that will be the liver. Then we have the gallbladder, as well as on the left side we have the stomach also, which is superiorly present. Coming to the inferior relations, all the coils of the intestine will be anteriorly as well as inferiorly present. Then the posterior relation will be the second part of the duodenum. As you can see, here is the second part of duodenum, and here is the transverse colon has been cut, so we can appreciate the structures behind. So one of the important structure is the second part of duodenum, as well as the pancreas also. Okay, so these are some of the important relations of the transverse colon. Now coming to important some structures called as colic flexures. Flexures means bending. The junction between the ascending colon and transverse colon, this is called as the right colic flexure. Right colic flexure. Okay. So it is also called as the hepatic flexure because the liver is present here. So this bend is called as the hepatic flexure or the right colic flexure. Similarly, on the left side, we have the left colic flexure, that bend, because it is in relation to the spleen here. This is called as splenic flexure. So you don't have to write whether it is right or left. Easily you can, because of the relation, you can say here hepatic flexure. Here you can say the splenic flexure. So this flexure is slightly higher compared to this one because here the liver is present. So it will push this flexure downwards, and this flexure is much more higher, more acute. Okay. Now coming to the rectum. So we'll discuss more this one in the next class, but here we briefly will introduce the rectum, beginning as the continuation of the sigmoid colon. This is the sigmoid colon. This is the S-shaped structure from the descending colon. The S part of the descending colon, that is called as the sigmoid colon. Okay. So it as the continuation, it will continue. The rectum will continue. Here is the rectum. So it will continue from the sigmoid colon at the level of S3. S3. Termination will continue as the anal canal. So will continue as the anal canal is below. Okay. So this is the continuation of the sigmoid colon, and then it will continue down at the inner canal. 1 inch below and in front of the tip of the coccyx. If you see here, this is the sacrum, and behind that is the coccyx. So it is in front of the coccyx. It ends the end is dilated to form the rectal ampulla. Later we'll study it is dilated. Before it ends, it forms a big large cavity that is called as the rectal ampulla, where the feces will be held before it passes through the anal canal. The total length of this is almost 5 inches or 13 centimeters. Okay. So some of the important relations in case of the male and female, there are some differences in male and female. In case of male, anterior relation of the rectum. So this is the rectum. Anteriorly, you can see these are the seminal vesicles, urinary bladder, as well as below we can see the prostate anteriorly. Okay. But in case of female, because we have the uterus and the vagina, so the anterior relation for the rectum will be the posterior wall of vagina instead of this urinary bladder, cecum, and prostate. These are absent. Cecum and prostate are absent in case of the female. So instead of that, there will be the vagina, anterior wall of the vagina. The posterior wall of the vagina will be in relation to the anterior wall of the rectum. Okay. So the bladder has been totally separated from the rectum, but here it is totally in contact. Okay. The posterior relation is same both in male and female. It will be the sacrum and the coccyx. Sacrum and the coccyx. Posterior relation is same. Only there is difference in the anterior relation. Now coming to some clinical aspects of this, you will study more in pathology, but he will just briefly discuss some important aspects. One is called as the diverticulosis. It is nothing but the herniation of the mucosa of the colon. A small part of, if you see here, if you take cross section, so this is the wall of the the intestine. So a part of the wall becomes weak and it gives diverticulum. It is herniation of the mucosa of the colon through the circular muscle cord between the tinea coli. It occurs through a weak point where the blood vessel pierce the muscle. So wherever the blood vessel supply, so that part will be weak, and that leads to diverticulosis. These are the small pouches, herniations which are formed. Okay. So this is called as the diverticulosis. Outside, this is how it looks like. Coming to the something called as volvulus, where because the mesentery of the sigmoid colon is long, it might rotate around itself. So the sigmoid colon and other parts of the colon might rotate itself. Okay, like this. Okay, it can obstruct the blood supply and cause gangrene. So if it is very severe, then it can totally block the blood supply and lead to gangrene. Then there are conditions called as intersusception, especially seen in case of children, where a part of the tube will enter into the other part of the tube. Okay, so this is called as the telescoping. One part of the intestine has entered into the other part. If you see here, you can appreciate here better. So this is the large part, and the small part has entered into it. This is called as the intersusception. This is a telescoping of a proximal of the ball into the lumen of the adjoining distal segment. It is commonly seen in case of children, and common forms are ileocolic, colocolic, as well as the ileal varieties. Okay, so all this again in detail we'll study when we go to the pathology. Okay, so these are some of the questions which you can read. Okay, so this is all about the small intestine and large intestine, and if you have any doubts regarding this, you can ask me. Any doubts?
No, thank you, doctor. Everything is
Thank
clear.
you.
Thank you, Doctor.
Okay, you'll have a 10 minutes break. After that, we'll start the next lecture. Okay, so now it is 54, 10:54. We'll start at 11:05, inshallah.